Good morning, dear students. It's my pleasure today to welcome you all in our continuation of our course content. I am Dr. Dua Ahmed Isa, Associate Professor of Medicinal Chemistry. I'm welcoming you all to attend with me 6 lectures through which we are going to discuss certain topics, completing or continuing the CNS drugs, starting with the sedatives, hypnotics, and anxiolytic agents, ending with the anti-epileptic drugs, general anesthetic agents, and stimulants. We are going to study together an interesting class of drugs, non-steroidal anti-inflammatory drugs. We are going to study the opioids together, and a very selective topic, that is the antihistaminergic agents. Today, inshallah, we are going to start together the study of sedatives, hypnotics, and anxiolytics. Next lecture, inshallah, will include the anti-epileptics, general anesthetics, and stimulants. So the rest of CNS derivatives will be achieved in 2 lectures. Before studying or tackling deeper information about these classes of drugs, it's very important to understand that we have certain neurotransmitters, certain chemical neurotransmitters in the CNS that are amino acid in nature, like the gamma aminobutyric acid, which is abbreviated as GABA, glycine, which is an amino acid, aspartic acid, and glutamic acid. As you can notice, there are 2 categories, one that is written in blue and the other is written in red. The one that is written in blue is inhibitory to the CNS, while the other one written in red is excitatory. It triggers the excitatory responses in the CNS, as well as the norepinephrine, that is considered of the monoamine. It is not an amino acid anymore. Dopamine and serotonin. There are some peptides that act as endogenous transmitters in the CNS, like the endorphin. And of course, the father of all neurotransmitter, the acetylcholine, that is an ester structure in nature. What is governing an inhibitory response, and how is an inhibitory response or effect generated? First of all, there is a stimulation of the inhibitory neurons, release of the neurotransmitter. Let's talk selectively now on the amino acids such as GABA or glycine, and then these neurotransmitters will definitely bind to their own appropriate receptor. Then this will increase the permeability to specific ions such as sodium or potassium, which will precipitate in hyperpolarization and inhibitory for postsynaptic potential. What I said is clarified in this scheme. We can notice the presynaptic neuron, where GABA is stored in vesicles after being synthesized, and it is released synaptically. It will act postsynaptically on its selective receptor, that is a GABA receptor. The GABA receptor will accept the neurotransmitter and will allow the chloride ion channel to open. This chloride ion channel being opened, a chloride influx will precipitate. This influx will cause a hyperpolarization state and inhibition of the excitation response. As you can see, there are different receptors present on the chloride ion channel, One of them is well recognized and well known, that is the GABA receptor. We can find benzodiazepine receptors and barbiturate receptors, and I want you to notice that these receptors are separate. They are in another place where GABA receptor present. So an inhibitory drug will be designed in order to influence the GABA, either by mimicking the GABA effect that will fit on perhaps the barbiturate receptor, benzodiazepine receptor, and in this case we can consider barbiturate and benzodiazepine as allosteric modulators regarding their effect, as long as they are not fitting the same receptor where GABA fits. This sure will enhance GABA effect. At the same time, we can find other drugs that are acting by enhancing GABA receptor indirectly by increasing the GABA biosynthesis, and in turn GABA being increased in biosynthesis will fit GABA receptor, or to prevent the GABA reuptake being accumulated, it will fit more the GABA receptor, or drugs that are designed to inhibit the GABA metabolism. In this case, GABA again will be accumulated in the synapse. All this will add to the GABA effect, so an end result is obtained is potentiated GABA effect. Now, what are we expected from a sedative, hypnotic, or an anxiolytic agent? These are going to suppress the CNS, leading to starting from suppression in behavior, depression in behavior, inducing calmness, producing sometimes some drowsiness, ending by losing consciousness. These sectors or categories of physiological responses can be used medicinally to treat anxiety, or to produce hypnosis, to precipitate or to achieve muscle relaxation, anti-epileptic effect. Sometimes they are used as anesthetic agents or pre-anesthetic medications. We can classify sedatives, hypnotics, and anxiolytics chemically into the following classes: barbiturates, that are subdivided according to their pharmacokinetic behavior into long-acting, intermediate-acting, short-acting, and ultra-short-acting. Non-barbiturates, this is the second chemical class, that are classified classification into inorganic bromides, aldehydes, acetylenes, acyclic ureoids, piperidine-diones, and Z-drugs. We are going to explore these areas. And a third class that is totally different, which is benzodiazepines and non-benzodiazepines. So we have barbiturates, non-barbiturates, benzodiazepines, and non-benzodiazepines. Starting with the barbiturate, we have to admit that this is the parent structure governing all CNS suppression, and maybe nowadays this class of drugs is not heavily used, even though it is mainly used in case of pre-anesthesia as pre-anesthetic agent, and it is used to treat convulsions in epileptic patients. But it is of very important consideration to study this class of drugs because we can specify certain influences of different concepts governing the acidity, governing the deposition on the receptor, governing the dependence approaches. All these are fundamental knowledge considerations to be undertaken. Barbiturates, they have their own use as sedatives, as I have already mentioned. They are known to cause tolerance dependence. We can find nowadays in market still anesthetic medications that are barbiturate in nature, anti-seizures treating epilepsy. And of course, the dose and the administration of the barbiturate will regulate and vary in its degree of CNS depression or suppression. Not only the dose taken or the route of administration, the chemistry of compound as well will have certain impact on this use. As I told you, barbiturates were the parent of all CNS derivatives even before the introduction of benzodiazepines. They are now limited in their therapeutic utility because of their tolerance, as I mentioned before. They have some toxicity. They might cause great CNS suppression. The tolerance and dependence, of course, is considered the important disadvantage of this class, and anesthetics and anti-seizures are the two main residues of barbiturates that are used nowadays. Starting from the mechanism of action that I have pointed before, they are considered as allosteric regulators to the chloride channel where the GABA receptor exists. So they are potentiating and prolonging the action of GABA by an allosteric effect. Their binding to their own receptor causes receptor changes in conformations to let the receptor more accepting and hosting the GABA and making the GABA fitting easier and firmer to the GABA receptor. This allosteric regulation and potentiation of GABA receptor will activate, as we have said before, the chloride channel, and influx will occur, hyperpolarization, and then less excitation to the CNS. Please have a look to this scheme. It's typically what we have clarified before, but you can here recognize the presence of two different additional receptors apart from the GABA binding site, which is the barbiturate binding site, and the benzodiazepine binding site. And in this case, as we told, it's a regulatory response causing conformational changes, making the GABA binding site more accepting, more tolerating, more hosting the GABA. As I told before, that barbiturates, they are suffering from tolerance and dependence side effects or mechanism, induced mechanism. There is what we call cross tolerance between barbiturates and benzodiazepines. What does this mean? This means that a patient that has developed a tolerance to barbiturate will definitely suffer tolerance to benzodiazepine. Let's discuss the general structure and numbering system of barbiturates. As we can see, it is a diaza 6-membered ring. It is a pyrimidine structure having in position number 2, 4, and 6 3 carbonyl functions. At position 1 and 3 is the presence of the 2 nitrogens of the pyrimidines. this is the structure of barbituric acid itself. To have an active barbiturate, definitely, and we are telling that we are causing CNS suppression. So I'm expecting that the structure is going to penetrate blood-brain barrier. Do you think barbituric acid alone, as it is written or drawn in front of us, is it susceptible to penetrate blood-brain barrier? No. That's why we are going to find different substitutions specifically at position number 5 and sometimes at position number 3 that will cause a lipid water partition coefficient that will increase that will increase the lipophilicity of the barbituric acid derivative so as to obtain a lipophilic hydrophilic balance, permitting better lipophilicity to be able to penetrate blood-brain barrier. The hydrophilicity, the main source of hydrophilicity is the pyrimidine trione ring, and the lipophilicity mainly is produced by the presence, or as I told you, of the two substitutions that are allocated at the 5 position. Do we need that barbiturate keeps certain ionization and hydrophilic potential? Sure. Don't forget that a part of the journey of the drug is to be transported through blood and to have some water solubility as long as it is not protein bound, to be able to transport through or to displace through the bloodstream. So barbiturate ionization and acidity, even salt formation, is important to be studied in order even to understand whether barbiturates are formulated maybe as sodium salts to be able to be administered intravenously. For instance, when I'm trying to give an intravenous injection of barbiturate, am I expecting that this barbiturate should be lipophilic to be given intravenously? No, certainly it should be hydrophilic. In this case, hydrophilic is meant here, or is expressed here by the ease of salt formation to be water soluble. Let's check the equation that is present in front of us. You can find here the acid form of the barbiturate, where the hydrogen here is easily lost in order to give a conjugate base, and this conjugate base, that is the anion form, should be stable enough to permit acidity. This negative charge will be delocalized to switch its position on the X atom, which is either oxygen or sulfur, as we are going to recognize later. And again, from the other side, this negative charge can be allocated on the other oxygen, permitting the presence of two extra conjugate bases where a negative charge might be present on the nitrogen or on the X atom at the 2 position, or on the X atom that is on the 6th position. So we can consider that barbiturate is containing an acidic residue, this proton that is easily lost, leaving a stable anion, permitting the presence of the barbiturate as an acidic entity, allowing the formation of sodium salt. This is not only the importance of the acidity or barbiturate. The barbiturate, being an anion, this is the form the barbiturate will fit its own receptor with. So I need, when barbiturate is hosted by the barbiturate receptor, that an ionic interaction occurs on the receptor site between the negative charge on the barbiturate molecule and a complementary positive charge on the receptor. So please consider with me, if this hydrogen is not present anymore, are we expecting any activity of this barbiturate as long as the negative charge is needed? Definitely not, because this hydrogen, if it is not present, there will be no possibility for negative charge formation, and hence no fitting on the receptor through ionic interaction. Coming to the structure activity relationship, the position number 5 is regulating the lipophilicity of the barbiturate molecule. Disubstitution is a must to be an active barbiturate. The length of the carbon skeleton on the substitution dictates the duration of action of the barbiturate. Branching is also a parameter to dictate this, to permit either short duration or long duration. Unsaturation, in addition to branching, are always recognized in shorter duration barbiturates. Do you think a polar alkyl function will be suitable for blood-brain barrier penetration? This nitrogen number 3 is either unsubstituted or substituted. When substituted, it is methylated, and this will enhance the lipid solubility. The carbon number 2 having the carbonyl group can be bioisosterically replaced, this carbonyl, by a thio function. Instead of CO, it will be CS, and in this case we are telling that this is a thiobarbiturate, keeping into consideration that the sulfur atom is potentiating the lipid solubility of the barbiturate. Let's again ask the same question. Are you expecting that nitrogen number 1 can be substituted in order to have a barbiturate that is active? It's your turn to answer this question. What about 1,3,5,5 tetrasubstitution? Do you think it will be active? Do you think it needs a further step of metabolic N-dealkylation? I appreciate if you have your own concept after hearing the previous information we discussed. We can here observe the pKa of the barbiturate and how it can penetrate blood-brain barrier. The lipophilicity of the substituents at position number 5 are very, very, very important in classifying and determining the duration and the onset of action of barbiturate. This is what I meant by formation of a sodium salt with the barbituric acid analog in order to formulate it as an intravenous injection, for instance, or being intravenously accepted. You know, of course, that an intravenous injection should be freely water soluble. As I told you that the position number 5 is dictating the duration of the barbituric acid analog? Yes. A long duration was always recognized by the presence of a phenyl group in addition to a saturated side chain, while shorter duration were always recognized by unsaturation and branching at position number 5. In this concern, we are able to classify barbiturates into long-acting barbiturates like phenobarbital, and as I demonstrated a while ago, that we are going to find a phenyl function and an unsaturated function at position number 5. Of course, I'm not asking you to study or by heart this info that the onset is between 30 and 60 minutes and the duration is lasting from 10 to 16, and no, I'm not asking you to consider this information by heart, but I'm asking you to understand that such derivatives having such long duration of action are suitable for anticonvulsant treatment. As long as one patient is administering an anticonvulsant therapy, of course he is asking for limited occur or happening of seizures outside home. That's why a duration of 10 to 16 hours is permitting this. That's why long-acting barbiturates are reserved as anticonvulsant medicines rather than inducing hypnosis or being sedatives or used as anxiolytic agent. They might be used for insomnia and anxiety and sometimes stress hypertension, but they are ideal due to their long duration for anticonvulsant treatment. You are going to ask me how it is low lipophilic in nature. Consider the presence of 3 pi electrons. 3 pi electrons that are delocalizing inside the benzene ring is imparting an electronic environment, a negative environment, decreasing the lipophilicity of the structure. That's why these drugs, once they are penetrable inside the blood-brain barrier, they are not easily going out, as we are going to discuss soon within minutes, the ultra short active ones. I can find intermediate and short acting barbiturates. I am asking you to not to separate much between them. Consider them as two categories in the same class, because the structure alone is not sufficiently defending that this one is an intermediate acting while this one is a short acting. So consider them as short to intermediate acting barbiturates. We are going to find here that the electrons, the 3 electrons were not present, no phenyl group present. We can find aliphatic substitutions, either unbranched with some level of branching in this butyl derivative. That's why it is called butobarbital, while secobarbital is keeping both unsaturation and branching. Again, please consider this knowledge. Just recognize them. Just have a look that the absence of 3 pi electron has imparted higher lipophilicity in both derivatives. Their duration of action is in favoring their use as sedatives and hypnotics, while it is not recommended to be used as anticonvulsant because the patient might develop seizures between doses. Coming to the ultra short acting barbiturates, something like the thiopental, for instance. Thiopental, we are going to find saturation and low level of branching. At the same time, we have a thio group that is allocated on position number 2. This thio group, in addition to the absence of a lot of pi electron, makes or render this structure very, very, very lipophilic. That's why these ultra short acting barbiturates are having a unique attitude. From a side, first of all, being acidic, an ionization will happen. The negative charge will be delocalized all over 1, 2, and 3 atoms, the nitrogen, the sulfur, and the oxygen. That's why it will be highly or rapidly transported after an intravenous injection, and then in front of the blood-brain barrier, the unionized species will be recovered. Being unionized and highly lipophilic, it is very rapidly penetrating blood-brain barrier, and at the same time a large amount of the dose is being stuck where in adipose tissue, and even being highly lipophilic, having the same velocity it has entered the blood-brain barrier, it has penetrated blood-brain barrier, it can come out of the blood-brain barrier, out of the brain, where it is stored again in adipose tissues. That's why these are having a very, very rapid effect, being highly displaced in blood and highly entering blood-brain barrier, and at the same time very, very, very short duration of action, as they are going to be stuck in adipose tissue and leaving blood-brain barrier. That's why such derivatives are suitable for pre-anesthesia. They are used as anesthetic agents, but of course they are not sufficient to cover the whole duration of the surgery. They are used as pre-medications, pre-anesthetic agents, just to initiate anesthesia. That's why the surgeon or the anesthesia physician is asking you to count. No one can go after 5. You are starting to count 1, 2, 3, 4, 5 after an intravenous injection of such a pre-anesthetic medication, and you are not able even to count behind or after 5 due to its very rapid onset. Barbital, that is the veronal, please have a look to it. It is the 5,5-diethyl barbituric acid. Amobarbital, please, I am asking you now to analyze the structure and to predict to which class it belongs. Is it long duration of action? Is it short to intermediate? Is it ultra short acting? You can analyze the structure, specify the branching, look for the presence of the sulfur to render it a thiobarbiturate, and then have or make your decision for the class of the drug. So pentobarbital and amobarbital both can be considered of which class? I want you to answer me. They are typical short to intermediate derivatives, while this derivative is considered as long acting. Please have a look to the thiamylal, again we can find a second derivative suitable for pre-anesthetic medication due to its high lipophilicity and short duration. The synthesis of these derivatives is very simple. We can rely on substitution at position number 5 of the barbiturate by using diethyl malonate and an alkyl iodide, just to replace the two hydrogens with the appropriate substitutions we want, and then a condensation reaction with urea, or even instead of urea we can use thiourea. This will synthesize the pyrimidine trione residue of the desired R groups. Coming to the metabolism of barbiturates, have the time to read this. It's expected. All these reactions, they have nothing, they didn't shift from any from what we have taken in metabolism, and I want you to notice that barbiturates are renally eliminated. As we discussed before, that barbiturates are causing tolerance and dependence. The main reason behind this is that they are enzyme inducers. Being enzyme inducers, they are causing an induction in cytochrome P450 microsomal enzymes network, even inducing their own metabolism. That's why a patient today that needs a certain amount of in milligrams of the dose, typically having its enzymes induced, it will need further and a further increase in dose to tolerate or to achieve the same response. That's why, being themselves enzymes inducers, they induce their own degradation and metabolism. At the same time, they are suffering from side effects. No, I don't want to say side effects. I want to say drug-drug interaction by inactivating other drugs, by enhancing their metabolism. I can see this in some anticoagulants. I can see this in glucocorticoids, oral contraceptives. For instance, a patient that is asthmatic and is depending on glucocorticoidal treatment with theophylline, for instance, I can find that the dose he used to take is not sufficient to elevate his suffer from the asthmatic situation, being the drug being self-metabolized and degraded. A woman that is taking oral contraceptive, for instance, might come pregnant. A patient that is treated with digoxin, the dose might be insufficient. It might be threatened, this patient, this cardiac patient. Some patients that are developing seizures and are treated with phenytoin, they might develop seizures while using barbiturates with phenytoin treatment, and so on. All this is leading to low quality of the concomitant used drug. Being eliminated in kidney by kidney, we can notice that we can enhance the ionization and the excretion of the barbiturate. Please have a look on this equation. Definitely barbiturate will be eliminated in its ionized form. So a pH level of urine above 8 will enhance its elimination, while a pH, an acidic pH, will decrease its renal elimination. As I told you, we are going to study some non-barbiturate derivatives, like the inorganic bromides, for instance. We know all that the bromide ion itself is being CNS suppressant. Aldehyde derivatives, and as you have noticed maybe in pharmacognosy labs, that chloral hydrate is inducing some sort of CNS sedation. That's because it is converted to chloral, and it is rapidly reduced even in liver. These three forms all are active, and they are producing CNS sedation until it is finally oxidized to the acetic acid analog that will be inactive. They are not used as drugs in the market now because of their odor. They are irritating in nature. So they are not used as medicines, but we have to understand that they are enhancing the GABA receptors. Paraldehyde is a trimeric molecule composed of three acetaldehyde. It has its limited use again for its triggering effect. It is very simply in large scale produced by polymerization of three acetaldehyde molecules. Acetylene derivatives, we can find a species like ethinamate. Ethinamate is highly lipid soluble, as we can deduce from the structure having the six-membered aliphatic ring. It has a rapid onset of action and short duration, and even it is rapidly metabolized. The acyclic ureides are an important class of derivatives that we might find some of them related in barbiturates to barbiturates by nature, like the carbromal. The carbromal is an aliphatic derivative, as we can see. It is an acyclic ureide. What is meant by acyclic? It is not cyclic, but it can in space acquire the same structure or the same topography, the same atom distribution as barbiturate, rendering it able to fit the barbiturate receptor. Meprobamate, which is the equanil, is a well-known drug that is acting as a skeletal muscle relaxant, producing some hypnosis and sedation. It is only recommended for short-term use. It has less toxicity than barbiturate. Again, this structure is an acyclic derivative. It is an acyclic derivative. It is a ureide derivative. I'm asking you, do you think it is a ureide derivative? Does it have NCON? Have a look on it. Does it have NCON? No, it is a dicarbamate analog. So the carbromal is an acyclic ureide, but this is a dicarbamate structure in nature. Piperidine diones, we can find the glutathione that is related in structure to barbiturate, but it is not a pyrimidine trione. It is only a pyridine dione structure, piperidine dione structure. This structure is related to barbiturate and is having the same effect by modulating the barbiturate receptor. The methylprilone is again a derivative that is expected to have an oxidation metabolic process here to convert it to the trione function so as to be able to fit the barbiturate receptor, and it has a hypnotic effect. We can notice this due to the 5-position substitution. It causes addiction as barbiturates do. These Z drugs are a known class of drugs. Because of their name, they are named Z drugs, like zolpidem or zalplon. They are belonging to different chemical cores. Zolpidem is an imidazopyridine. Imidazo, we can find the imidazo, the 5-membered ring having 1,3-nitrogen fused to a pyridine ring. That's why this stilnox or this derivative, the zolpidem, is imidazopyridine analog, while the pyrazolopyrimidine analog, which is the zalplon. Where is the pyrazolo? Pyrazolo is different from imidazolo. I want you to revise this. A pyrazolo is a 5-membered ring still, but it has the nitrogen at position 1, 2. And instead of being pyridine like zolpidem, it is a pyrimidine. They are all bioisosteric analogs. These derivatives are having nothing to do with the barbiturate receptor. On the other hand, they are acting as GABA agonists. They are able to fit the GABA receptor itself as if they are GABA. That's why they have reduced ability for physical dependence and tolerance. They have fewer side effects. They are safer used when compared to barbiturates and benzodiazepines. Now I want you to read this paragraph. One of the pharmacokinetic properties of zalplon is being short acting. That's why zalplon is reserved for people who have difficulty to go to sleep. I cannot use zalplon, the short-acting drug, for patients that have difficulty to maintain sleep. Just have a look to this and consider that the different pharmacokinetic properties owing to different metabolic concerns and distribution and even protein binding might affect the medicinal use of the drug. Let's now go to part 2, where we are going to discuss the drugs that are benzodiazepines or non-benzodiazepine in nature. Thank you.